Hello, we are one of the emergency medicine group projects, and we will be presenting on racial disparities in the emergency department and emergency medicine. Our group members are Andrea, Andriana, Emmanuel, Joy, and William. My name is Erica, and I will go ahead and get started. Next. Emergency medicine is a medical specialty in which sudden injuries or illnesses are diagnosed and treated. It can be practiced in various settings such as emergency rooms, urgent care clinics, disaster sites, or even telehealth. The emergency department is a department specializing in emergency medicine and can be considered a hub for patient entry, in which patients of various ages and illnesses come here seeking immediate care. This department has limited resources, so the right attention must be given to the right people at the right time. To provide the best treatment, an organized system is followed known as triage. With this, injured patients are allocated treatment according to their need for emergency medical attention. Although patients are expecting to receive the best care in a short amount of time, why are wait times typically so long? This can lead to overcrowding, an issue often seen in the emergency department. Next.
So like Erica mentioned, there is a system in place to make sure that the patients that need the most care are treated first. And that is the system that's used is the Emergency Severity Index on a scale of 1 to 5, 1 being most urgent and 5 being least urgent. But unfortunately, a lot of patients of color are either just put on the back burner or they end up having a longer wait time because of things like implicit bias and um, just what can be just pure racism. So those are some of the racial disparities that we see um, in the emergency department. Black patients and those in other racial or ethnic groups are less likely than white patients to receive immediate or urgent ESI scores. So what that means is that they're just sitting in the waiting room waiting to be assessed, even to see if they need care or if they just need to be just evaluated. Um, Also with Hispanic patients, they endure actually the longest wait time because of the language gap. There aren't enough translators in the hospital, so there has to be time taken to make sure that communication is um, people are able to communicate well with the patients, and that takes that wastes time for the patient to get adequate care that they need. You can go on to the next slide.
So, one of the main emergencies that is encountered in emergency medicine that we wanted to focus on is the gunshot wound, or the GSW. So before we explain in further detail the disparities in care that patients receive because of their race, we wanted to first identify the different disparities in the sustainment of gunshot wounds themselves. So in a study conducted between 2016 and 2017 that was uploaded to the Kansas Journal of Medicine, the racial breakdown of gunshot wound patients was 49% white, 26.5% black, and 19.6% Hispanic. Hispanic patients were the youngest on average, with an average age of 25.8 years, while white patients were the oldest, with an average age of 34.3 years. Furthermore, it was found that a whopping 96% of black patients sustained GSWs as a result of assault, compared to only 26.9% of white patients. Finally, with the utilization of geographic incident mapping, it was found that GSWs are most commonly occurring in neighborhoods with both low income and high rates of minority residents, as well as in more downtown areas of the state. And you go on to the next slide.
Disparities in care. One of the main racial disparities in the care distributed is the type of center patients are administered to. The main difference between pediatric trauma centers and adult trauma centers are the treatment used and social work follow-up. African American adolescents 15 to 18 years of age sustaining GSWs were most likely to be administered to ATCs than PTCs, associated with increased opioid prescription, increasing the likelihood of developing addiction post-treatment. decrease with social work support, increased chance of returning to the ED within 6 months of discharge. Next.
Another example of disparities in the emergency medicine is an early delivery. An emergency C-section is performed when it is the best and safest option for the patient and the baby in an emergency. This can be due to health reasons and is different from the scheduled C-section, which is scheduled at the beginning of pregnancy, and different from an unplanned C-section, which can be scheduled hours, days, or weeks before the delivery. This is a major surgery that requires a team of healthcare professionals. And due to the nature of the situation, this surgery needs to happen fast. This includes the prepping for the surgery and the administering of anesthesia. In some cases, there may not even be enough time for this. Because this delivery needs to happen quickly, it needs to be done in 30 minutes, but often can take up to 75 minutes. And the incision is likely to be different from a normal C-section, which is horizontal. In an emergency C-section, this incision will be vertical. And because this decision is often made very quickly due to it being an emergency, the patient does not have enough time to process this, which is why they are often advised to seek mental health care after and um, excuse me, and advised to do follow-up appointments because they are at a higher risk for postpartum depression and post-traumatic stress disorder. We can move on to the next slide.
So unfortunately, there are also many racial disparities that occur in labor and delivery. Unfortunately, Black women are 3 times more likely to die from pregnancy-related causes than white women. Some of these causes or factors that implement or cause racial disparities are the quality of healthcare, underlying chronic conditions, for example, diabetes, hypertension, or cardiac issues, implicit bias, and structural racism. As Andrea said, having like for example, an emergency C-section, that is a very traumatic surgery to have. And as a Black woman, many Black women are, may come from low income families, low income household. So they may not have the resources to consult for aftercare and consult um, for mental health issues. And that's when we talk about the quality of healthcare. Are the mental health issues being addressed? Is the postnatal and prenatal care of is it in a qualitative, is it quality, so that when African American women are giving birth, they have little to no issues, or they are not as stressed when they're about to deliver their child. Um, Also, when talking about different health conditions, in a recent study by the National Institute of Health, led by Dr. Marian McDormand, they found that for Black women, preeclampsia and eclampsia was the leading cause of maternal death, followed by postpartum cardiomyopathy, embolism, and hemorrhage. So there are things happening after labor and delivery for Black women that are not able to be treated because of the lack of quality in healthcare. You can go to the next slide.
So in order to combat disparities in medicine, we need to start by having more diverse physicians, whether that be in their race or ethnicity, gender, or any other identity to help normalize diversity in the medical field. And so physicians also need to recognize, name, and understand their implicit biases, such as race and ethnicity bias, age bias, gender bias, LGBTQ plus community bias, and ability bias, in order to control their behaviors and allow them to practice tolerance, respect, and open-mindedness to those different from them. Only then will we be able to move forward in fixing the many disparities we often see in medicine. And we just wanted to say thank you to our project coordinator, Limi Ahmed, and everyone in the Doctors on Board program for such a great experience throughout this entire program. And thank you to everybody for listening.